Good evening, ladies and gentlemen. Happy Halloween. We're here with treats, I hope no tricks. And welcome to the annual Duncan Sinclair Lecture in Health Services and Policy Research. My name's David Walker and I'm Executive Director of the Queen's School of Policy Studies. This lecture series was established by Canada's Medical Research Council, now the Canadian Institutes for Health Research, Queen's Faculty of Health Sciences, and with sustenance by the generosity of Duncan and the late Leona Sinclair. Organized each year by Queen's School of Policy Studies and the Centre for Health Services and Policy Research, we bring distinguished guests to discuss topics of importance in the health policy domain. Duncan Sinclair is a distinguished Canadian who needs little introduction to our community at Queen's, and I draw your attention to the program which describes his distinguished career. Dean of 2 faculties, multiple vice principalships at Queen's, he has contributed so very much within and outside the walls of Queen's. His roles on a variety of government committees, councils, and commissions had an enormous impact on the structures and policies of healthcare, and always on the minds of the generations of students in both health and public policy to this very day, whom he has taught and inspired. He and I spent the afternoon with our 836 class, many of whom are here with us tonight. And most recently, Duncan has entered the world as a blogger par excellence with other members of the Queen's Health Policy Council. If you're interested, go to www.queensu.ca/SPS for even more inspiration. We thank you, Duncan. Now I'd like to call on Dr. Chris Simpson, Vice Dean Clinical in the Faculty of Health Sciences, a cardiologist of rhythm, member of the same Health Policy Council, and past president of the Canadian Medical Association, to introduce our very special guest lecturer.
Well, thank you very much, and thanks to all of you for being here. You may notice that the cellular coverage in here may not be great. So those of you who are Queen's students or who have a Queen's appointment will notice that your Wi-Fi signal is here. And for those who don't, you can come to see me about a Queen's appointment outside afterwards, and we'll look after that for you. So it gives me pleasure to welcome you all here today and welcome this year's Sinclair lecturer, André Picard. André, of course, is the health columnist at the Globe and Mail and has emerged as one of Canada's most influential public policy writers. His latest book, Matters of Life and Death, Public Health Issues in Canada, is the latest in a long line of bestsellers, including The Path to Healthcare Reform, Policies and Politics, Critical Care, Canadian Nurses Speak for Change, The Gift of Death, Confronting Canada's Tainted Blood Tragedy, and A Call to Alms, The New Face of Charity in Canada. He's a multiple prize winner, including the Michener Award for Meritorious Public Service Journalism, the Canadian Policy Research Award, and the Atkinson Fellowship for Public Policy Research. In 2002, he received the Centennial Prize of the Pan American Health Organization as the top public health reporter in the Americas. In 2005, he was named Canada's first public health hero by the Canadian Public Health Association. And in 2007, he was honored as a champion of mental health. André is also an 8-time finalist for the National Newspaper Awards, Canada's version of the Pulitzer Prize. In 2010, he was crowned as the country's top newspaper columnist. He's been the recipient of the Canadian Nurses Award, Canadian Nurses Association Award of Excellence for Healthcare Reporting, the Nursing in the Media Award of the Registered Nurses Association of Ontario, the International Media Prize of Sigma Theta Tau, the Nursing Honor Society, and the Science and Society Book Prize. In 2012, he was the recipient of the Queen Elizabeth II Diamond Jubilee Medal for his contributions to improving healthcare in Canada. He's also been awarded honorary doctorates by the University of Ontario Institute of Technology, the University of Manitoba, the Laurentian University, the University of Toronto, the University of British Columbia, and Carleton. Most recently, though, and perhaps most importantly, André received a star on the North Bay Walk of Fame. He is a prolific social media enthusiast. He has tweeted over 86,000 tweets. He's followed by every Twitter user in the country who's interested in health and social issues, health policy, and equity. His profile says retweets are not endorsements, but I can tell you that everyone covets the Picard retweet. It speaks to the profound respect that we all have for this man. He's one of the good guys who tells it like it is without being pejorative. He brings honor and nobility not only to his profession, but to a public discourse which seems so predisposed to degeneration in this era of fake news. We know we can trust André to say brave things, to be principled in his analyses and in his critiques, and to stand for things that really matter. So André, thanks for coming back to Kingston to visit with us again. We'll look forward to your talk and conversation around stumbling blocks to healthcare reform, and I will be tweeting throughout.
Wow, thank you, Chris, for that very extensive and almost funereal introduction. I see you got the email from my mom, so there are no stone left unturned there. Thank you. So I have to begin by saying tonight what an honor and privilege it is to give the Duncan Sinclair lecture. It's also quite daunting, especially with Duncan Sinclair in the audience. Dr. Sinclair has made an enormous contribution to Canadian healthcare and healthcare around the world as an academic, a teacher, and leader on health policy and health systems reform. It's no wonder that he's in the Canadian Medical Hall of Fame and has many, many other honors, as you heard in his introduction. I also want to begin by acknowledging that Queen's University is situated on the traditional lands of the Anishinaabe and Haudenosaunee territories. I think this type of acknowledgement is a recognition of our history, and it's also a small but important gesture of reconciliation, so I hope you will take it in that spirit. Also, I can't visit Kingston without noting the tragic loss of Gord Downey. As a big music fan, I know there are close friends here, and I want to extend my condolences to them publicly. Like every Canadian, I have a tragically hip story, and I feel a need to share it, so I'm going to do that. I first saw the band play here in Kingston during their formative years, and actually my formative years. It was 1984 at Alfie's Pub at Queen's, and I was attending a student journalism conference. In fact, I began my career in journalism as a record reviewer at a student paper. Now, people, when I tweeted about this, people said, wow, 84, you're really at the cutting edge. But I have to set the record straight. I don't want you to think I was some prescient music guru. I just happened to be in a bar, and they were playing. And to be honest, I didn't think they were anything but an energetic bar band that did decent Doors covers. Now, I was proved wrong, as were many others, and that might help explain why I'm a health reporter and not a music reporter anymore. So, now, anyhow, to the topic at hand, which is a little more serious. And before that, I guess I should make a couple of quick technical points. You'll notice there's no screen here, there's no PowerPoint or any other bells and whistles. I'm just going to stand up here and talk. To me, in academic settings and in healthcare more generally, we tend to get really enamored with technology, and we often forget that the essence of good communication is talking and listening. Without that, you don't have good healthcare. So I'm going to do that. Those of you who know Dr. Sinclair know that he's a superb communicator, and I know he wouldn't use PowerPoint as a crutch, so I'm going to take him as my inspiration tonight. We're going old school tonight. Now, that being said, I'm not a complete technophobe. You did hear a little bit about my Twitter addiction. So I would invite you to use your communications tools, if you have service, and invite others who can't be here IRL into the conversation. So instead of telling you to turn your phones off, I always invite people to turn their phones on and use them to communicate with others. You can find me and tag me if you like on any number of social media platforms. I have the same handle everywhere, Picard on Health. I'm on Twitter, Facebook, Instagram, Snapchat, Tumblr, Grindr, Tinder, etc. I know, very extensive social media use. So, the topic for tonight. It's healthcare reform. So I want to start with a question, and I can see you guys more or less with the blinding lights, but I want to ask if there's anyone here who thinks that the Canadian healthcare system is perfect, that it doesn't need some improvements. Anyone? I get this same kind of response when I ask who wants to live in a nursing home. I may ask you that one later. So, no one thinks so. No one thinks it's perfect. So, to begin with, we all agree that reform is needed. So I have a relatively easy task, I think, to convince you that reform is needed. But I'm going to talk about why it's not happening. I think we can probably all agree too, I don't have to do a show of hands on this one, we can probably all agree that when it comes to health reform, there's a lot more talk than there is action. We talk and talk about it, and I'll elaborate that in a minute. But it doesn't seem to be a lot going on. So what I want to do tonight is spend my time discussing that paradox. Why do we talk so much about reform but do so little? More specifically, I want to examine the impediments to healthcare reform. And there are many. Before I do, I think it's equally important to examine what needs to be fixed. If we think the system needs to be reformed, well, we need to identify where. And first and foremost, I think if we want to fix the system, we have to acknowledge that we need to create a system. Because we don't really have a health system in Canada. We have 14 different jurisdictions with different variations of systems, with many silos within each. There's no Canadian healthcare system to speak of. So I will use that term tonight euphemistically, because it doesn't exist yet. But hopefully, I met a lot of you younger people here tonight. By the time you're done, there will be a Canadian health system. And I hope I can prod you along with some words tonight. Now, as a journalist, I tend to write from a consumer perspective. I always put the patient, the family perspective at the forefront. Health professionals are important, but they're not as important as the people who get care. So I want to start with a really fundamental question. And I think in Canadian healthcare, we don't ask the basic questions often enough. And to me, the most important and basic question is, what do patients want? Or, if you prefer, what do patients need from a healthcare system or non-system? Now, having said that, having posed that question, I should note that healthcare seems to be the only area in our lives where people can have needs, but they can't have wants. We never ask patients what they want. We often tell them what they need, what they can have, but we don't ask them what they really want. Our approach to healthcare is very directive. Some would say patronizing. I would say undemocratic. We don't value choice or preferences. And that's concerning, and it's especially concerning in issues like end-of-life care and assisted death. The choice is really important. People's values matter to them, and they should have choice. Now, I'm going to say a little bit about choice a little later, but I want to get back to that question. What do patients want? Now, I've spent many years pondering that question. Maybe I don't have much of a life. You can judge that from my long list of social media. But I think that after all this time, I think I've managed to boil it down to a very simple phrase. I think patients and caregivers want care that's prompt, necessary, safe, affordable, and respectful. Now think for a minute, the last time you were in a healthcare system or a part of the healthcare system. Is that what you got? Did we deliver on that expectation? Prompt, necessary, safe, affordable, respectful. I don't think we do it often enough. We do it sometimes, but not all the time. When you're at the right place, at the right time, you get superb medical care in Canada, as good as anywhere in the world, and we should be proud of that. And most people get good care most of the time, but that's not good enough. And we in the media, the critique of the media is that we're very negative. We only write about the bad stuff. But there's a reason for that. We see ourselves as watchdogs. It's not good enough to forget some patients. We do well, but we struggle in every one of the categories I mentioned. Now, prompt is the most glaring of the failures. We're not very prompt. Canada's wait times are common. They're often epic. When I travel around the world, I say I'm from Canada if I'm talking to people in other healthcare systems. What do they know about Canada? That's the country where you wait. That's not a very good reputation to have, but it's a fair one. It's an accurate one. But I think it's unnecessary. And again, I'll elaborate that on a bit more. Second point, unnecessary. or necessary. There's a lot of unnecessary care. Study after study shows that about 30% of our health interventions in Canada are unhelpful. Sometimes they're even harmful. So we're not doing well on that count. Is care safe? Well, adverse events, or what we in the media call medical errors, not a precise term, but juicier than adverse events. Adverse events result to somewhere between 11,000 and 24,000 deaths a year in Canada. That makes them one of the leading causes of death in the country. So we could do a little better on the safety front. And I'm not suggesting all of those deaths are avoidable. Medicine is fast-moving, it's difficult, it's complex. We can't avoid all those, but we can avoid lots of them. We can do better. Is care affordable? Well, physician and hospital care it's free. And whenever I say the word free tonight, I'm going to be using that in quotes, because I hope you know that we pay for our health care, and we pay dearly. We pay with our taxes, but it doesn't mean it's free. But beyond physician and hospital care, we need a lot more care. Drugs, home care, long-term care, rehab, vision care, hearing aids, dental care. These are often unaffordable. They're just as important. Again, I'll elaborate a bit later. Finally, is care respectful? On a one-on-one basis, I think a lot of the time the answer to that is yes. Again, superb care we get from our caregivers. But more broadly, I don't think the system is very respectful, in part because it isn't a system, but it certainly isn't patient-centered or person-centered. Our system often puts the needs and wants of providers and institutions ahead of those of patients. Again, that's not what patients want, and it's not what they need. The health system in Canada is, quote, disjointed, onerous, and opaque. That was the conclusion of a recent review of the Ontario health system. Pretty damning, but pretty accurate. Now, you may have noted that none of these shortcomings I mentioned were strictly medical in nature. Medicine is actually fine in this country. It's doing great. We have excellent medical education, doctors, nurses, all other health professionals. The reason we have waits, unnecessary care, medical errors, unaffordable care, and lack of patient-centeredness is not because we have bad medicine, it's because we have poor structures. We have profound structural problems. That sounds boring, but it's true, and it's necessary to address it. Almost all our problems are administrative and engineering in nature. They're organizational, not medical. That's why I'm so glad that many of the health policy students are out tonight. Your work is just as important as that of doctors and nurses, because they can't do their work without you. There has to be more of a symbiosis and a mutual respect between the two. And I think there's one of the most unhealthy things in our system is the bad-mouthing of bureaucracy. Systems of this size don't run themselves. We need good administrators and empowered administrators, as well as we need good doctors and empowered doctors. So if there's one thing you retain from my lecture tonight, I hope it's this. We won't fix healthcare simply with more medicine. We'll fix it with better engineering and better management, and a desire to embrace these. So how did we get to this point where our beloved Medicare system is so rickety and inadequate? To answer that question, I think we need to delve a bit into the past to understand how we got here. Now, I apologize in advance to those of you who've heard me speak before, and a couple of you mentioned it to me. I don't know why they were wearing earplugs, but they said they'd heard me before. But I do always harp on this point. I do harp a lot about history, and one of my books was essentially a history of Medicare with a few recommendations on how to fix things. And I'm going to summarize that book here very briefly. And I'm going to skip over the first 400 or so years of healthcare in Canada and go right to the 1950s. Because our health system and health insurance system that we have today were both fashioned in the 1950s and 1960s, what we call Medicare. In the post-war years, Canada was a very young country. We were in the midst of a baby boom. The average age was 27. Life expectancy was 67. That, by the way, is why we have a retirement age of 65. We assume most people would die and we wouldn't have to pay them pensions. The actuaries didn't do so well on that one. But I want to make the point it was a very different era. And in this era, when Medicare was born, care was very different too. It was principally acute care. A lot of women having babies, and then acute issues, heart attacks, injuries, cancer. But a lot of people who went to the hospital to die. That was the reality. So what did we do? We designed a system to meet those needs. It was entirely appropriate. We wanted to get people in and out of hospital quickly, alive or dead, that was the reality. And physicians treated specific concerns on a fee-for-service basis. A sensible approach for that population. Today, we live in a different world. Canada is one of the oldest countries on the planet. The average age here is 47. Life expectancy is 82 and rising. And even that understates how long people live. Because if you live to 65 now, you can expect to live in another 23, 24 years on average, almost to 100. We're a very old country and getting older. The vast majority of care today is chronic care. People enter the health system and they stay there. They stay there for months and years and decades. People are more likely to have multiple morbidities than specific health concerns. Very different world. So what does this quick comparison between generations tell us? I think most of all it tells us that Medicare is out of date. It hasn't kept up with demographics. We're essentially trying to deliver 21st century care with a 1950s model. What we need today is a Tesla of a health system, and we have an Edsel for the car lovers among you. By failing to reform and modernize our structure for the delivery and payment of care, Canada has actually gone from being one of the first countries to embrace universal health care to the country with the least universal health system in the developed world. Again, not a proud badge to wear, the least universal system. So how do we fix this? How do we modernize? Now, the good news is that we have the answer to that question. There are many countries we can learn from, and I'm a particular fan of the Nordic countries, but I won't talk a lot about them tonight. Because here in Canada, we've studied the issue of health reform to death. There's one thing that our country does better than any country in the world, and that's study the health system. Since the advent of Medicare, there have been more than 40 public inquiries, royal commissions and such, that have studied the health system and made recommendations on how to fix it. Vast forests have been raised to produce blueprints for change, but the change has never been implemented, except in dribs and drabs. When we implement reports in Canada, we always do it half-assedly, and that's almost worse than not doing it at all. Now, what's interesting about these reports, and when I wrote my book looking at the history of Medicare and reform, what I realized that there's quite broad unanimity in what needs to be fixed. Cuts across political lines, provinces, generations, and I think that should be uplifting. We know exactly what we need to do, and it can be summarized pretty briefly. So I'm going to summarize it for you, all these reports, vast forests, in 6 quick points. So this is what the experts say. First and foremost, we have to fix primary care. We need to take our hospital-based system and turn it on its head and make community-based care, primary care, the focus. Now that doesn't mean shutting down all the hospitals and sending people into the streets. It means treating people where they want to be treated, and appropriately and efficiently. The common trait of the world's best health systems is that they get primary care right. Every patient has a medical home, a central coordinating point for all their care, whether it's preventive, acute, or chronic. And they have an electronic record to track their care. Canada is the only country I know of that has something called orphan patients. 15% of our population has no primary care provider. That's crazy. It's crazy. I was trying to struggle for a better word. Number 2, vast unanimity that we need to do something about drugs. We need to extend universal health coverage to prescriptions. Currently, through a patchwork of public and private plans, about 27 million Canadians have drug coverage. That means about 7 million don't have coverage. And to me, that offends the very notion of Medicare, that no one should be denied care because they can't afford it. Now, pharmacare is getting a lot of discussion these days, and that's good, but it's not getting a lot of action. Outside of here in Ontario, where they're going to extend pharmacare to up to the age of 25. But the paradox there is we're going to provide insurance, drug insurance, to those who least need it. So it's a start, but it's perhaps not the best start. 3, community care. We need to treat people where they live, in the community. Again, this is what the best health systems do. Institutional care is important, but it should be reserved for acute treatments and for people who won't be safe in the community. It shouldn't be the default, and it is in Canada. 4, human resources. Really crucial. About 60% of all our health spending is for labor. That's not a bad thing, actually. Healthcare should be a labor-intensive, hands-on business. It should be about people, people helping people. But shouldn't we have some semblance of a health human resource plan? We kind of decide how many people can be admitted to nursing school and dental school and medical school, but that's not a plan. That's, again, kind of seat-of-the-pants stuff. We also need to make sure that all health workers work to their full scope of practice and that they actually spend their time with people, not pushing paper around. And those of you who are on the front lines know that there's a lot of paper to push around. Modern healthcare also requires that people work in teams, interdisciplinary care, to use the jargon. Again, that's not happening now, at least not routinely. Number 5, social determinants of health. Since Medicare was created, we've recognized that healthcare is more than sickness care. To be healthy, people need a decent income, a roof over their heads, nutritious food, a safe physical environment, and a sense of belonging. The other common trait of excellent health systems is that they haven't divorced the social health welfare system from the health system. They work in a coordinated fashion, not at cross purposes. And again, I don't think that can be said for Canada. We used to have a Minister of Health and Welfare, but now we have a Minister of Health and no Minister of Welfare. I'm not sure we have our priorities right there. Number 6, and this one's often forgotten, but every report has always talked about the importance of quality. As I said earlier, patients want care that's prompt, necessary, safe, affordable, and respectful. If you summarize that in a word, what they want is quality care. And all the research tells us that the most effective way to get the care that's cost-effective and appropriate is to put the emphasis on quality. When you deliver quality care, the other stuff works itself out. Now that seems like a lot to do, a pretty long shopping list. But as I've mentioned, many other countries have done that. They've made these adjustments over time. Canada has some catching up to do. It doesn't mean we can't do it, it just means we're going to have to work a little harder because we've let ourselves fall behind in the race. Now I want to stress too that while we're laggards on reform, I don't want to suggest in any way that we've been standing still. I've been writing about healthcare at the Globe for 30 years now. Healthcare today is infinitely better than it was 30 years ago. But our expectations are much higher, and they should be. We're just falling a little bit behind every day because we're not changing fast enough. While the structure of our Medicare system is dated, we can't forget that we've made many improvements. We have a lot to build on. Change is happening, but we really need to accelerate it. Fixes are happening, but they need to happen in a less reactive and less haphazard fashion, a more organized fashion. So after all this background, I finally arrived at the crux of tonight's talk. And I'm checking my watch to see if I have actually time left to actually talk about the crux, but I do. So that's what I want to spend the rest of the night talking about. What are the impediments to reform? Now in journalism, we'd call this burying the lead. In an academic setting, though, we like to keep you hanging for a while before we actually get to the point. So I've tried to be a good academic tonight. Now, I think there are 5 main impediments to reform. But before I enumerate them, I have another skill testing question for the audience. I want to know if anyone can tell me what's the mission statement for Canadian Medicare? And if you guess right, I'll give you a book. Can anybody give me the mission statement? That is right, but that's not a mission statement, so you don't get a book. But you're right, there is no mission statement. And I think to me that's the number one impediment to healthcare reform. We have a startling lack of vision. Last year we spent $228 billion on healthcare. That's an average of $6,000 per Canadian. And we had no stated purpose for doing so, other than spending more money than last year. And we do that very well. Now, a few years ago, I was visiting Medtronic Canada, which has a plant in suburban Toronto. And if any of you had the chance, I'd recommend you go there because they have this fabulous museum of pacemakers, which is why I went out there. The founder of Medtronic actually created the first pacemaker in his garage in Minneapolis. That's an aside. Anyhow, at the front door of Medtronic headquarters, they have a brass plaque. And on that plaque is the company's mission statement: to contribute to human welfare by application of biomedical engineering in the research, design, manufacture, and sale of instruments or appliances that alleviate pain, restore health, and extend life. It's pretty clear what they do. Currently, the closest thing Canada has to a mission statement is something that Tommy Douglas said on the campaign trail in the late 1950s. He said this: "No one should lose their farm to pay for essential health care." That's a philosophy that is a good one, but it's not elaborate enough. That's not a mission statement. That's a political promise. One that he actually followed through on, which is shocking in itself. Now, presumably the purpose of a healthcare system, a universal healthcare system, is to ensure that people are healthy enough to be productive members of society so they can contribute to the economy, raise their families, and contribute to society more broadly. Its secondary purpose is to redistribute wealth and power, to blunt inequality a bit by ensuring that no one is denied care due to an inability to pay. So there's a social mission there. So why don't we articulate our values more explicitly? Why not something like this? The mission of Medicare is to improve the lives of all Canadians by striving to alleviate pain, restore health, and extend life, while ensuring that no one is denied access to care based on race, gender, disability, or ability to pay. That's a crude, quickly done draft that I just did off the top of my head. But my point here is that if we truly believe in the concept of universal health care, if we have values and a collective moral responsibility to the vulnerable, which presumably we do, then shouldn't we say so explicitly? Shouldn't we have a mission statement? Now, beyond the grand statement of purpose, I think we also need clearly stated public health goals. I'll give you an example of one I'd like to see. Canada should reduce the child mortality rate from 5.7 per thousand live births to 2.5 per thousand. The first number I gave you was Canada's, the second was Finland. We have twice the number of child deaths of Finland. No excuse for that. We're never going to fix that unless we make it an explicit goal to do so. If you don't have improvement goals, how do you improve? You don't. You just limp along, and that's what we do in Canada. Number two, another major impediment to reform is politics. Joey Smallwood, the longtime Premier of Newfoundland and a father of Confederation, is purported to have said this: "I never had a discussion about healthcare that didn't lose me votes." Now, I'm not sure if he said it, but I know that that attitude still prevails. It's pervasive and it's paralyzing. Politicians see healthcare reform as a lose-lose proposition. Now, in Canada, unlike the US, there's actually very little partisan debate about healthcare. There is, in fact, striking unanimity about the benefits of universal healthcare. NDP, Liberal, Conservative platforms are identical. No one differs on that, and that's great to a certain extent. But the paradox is it leads to virtually no discussion of reform or improvement. Our election campaigns are largely healthcare reform-free zones. Again, that doesn't give us any incentive to do better. And once in office, almost all our political decision makers spend their time doing reactive things, responding to the newspaper headlines. Health ministers tend to see their roles as being firefighters, not fire prevention officers. They got to keep the Prime Minister out of trouble. That's their job. That doesn't create a need to improve things. I don't think we'll ever innovate if our politicians and policymakers spend all their time looking back and butt covering instead of looking forward and taking risks. And when was the last time you saw any risky program implemented in Canada? We place things safe. Number 3, history. I can't think of another country that is a prisoner of history as much as Canada, especially in the health field. We mythologize Medicare and we deify Tommy Douglas. Just the other day, I was watching Bernie Sanders give a speech at the University of Toronto, and the crowd actually cheered wildly every time he mentioned the name Tommy Douglas. Being a smart politician, he mentioned his name many times. And I love Tommy Douglas as much as the next guy. But, as I said, the Medicare system was wonderful in the 1950s and 60s. But nostalgia is standing in the way of improvement. Every time someone suggests a change, the name of Reverend Tommy Douglas is invoked. The implication being that a horror of biblical proportion will rain down on anyone who dares mess with our sacred Medicare. And if you don't believe me, you can read my Twitter feed on the days when I diss Medicare, which is most days. Lovingly, of course. Now, Canadians, and their politicians in particular, also have the annoying habit of saying things like this: Medicare is what defines us as Canadians. One of the phrases I hate the most. Medicare is an insurance program. Personally, I don't want to be defined by an insurance program. Car insurance, house insurance, health insurance, those are things that are useful, but they don't define me, and they certainly don't define my country or my nation. I especially don't want to be defined by an insurance program that's inadequate and outdated, and I hope you don't want to be either. Number 4, self-interest. Almost everyone would benefit from profound health reform, from creating a system and making a good system. At least every patient would. But there would be losers, there's no question. And again, we're a bit touchy about that. We don't like to talk about that. If we do what every study and inquiry has proposed and shift our focus away from hospital-based, physician-controlled health system, create a community-based care system delivered by interdisciplinary teams, one could imagine that some hospitals and some physicians would come out losers in this. That's a reality. Nurses would also see their roles change quite a bit too. So would labor unions. Having true patient-centered care would take some power away from providers and administrators across the board. Now, it's not a coincidence that those with the most power and resources right now stand to lose the most. That's the only way you can change, is change the most powerful. That's how revolution works, even evolution. So self-interested lobby groups ferociously defend the status quo, but they do so behind a veneer of promoting reform. So nothing ultimately happens. Of course, no one says, we want the status quo, we love that. Nobody says that, because that would be political suicide. What they say is this: they say, we need more money to do what we're doing. We need more money to do the same thing. What they say, though not in as many words, is that everyone should change except them. Everybody has wonderful reform ideas for others. Very few have ideas for reforming their own profession or their own institutions. And that's what I always ask people who bring me reports and suggestions. I said, fabulous, but what are you going to do? What are you going to do today? What are you going to do tomorrow? Because that's where it has to begin. Everybody has to put a little bit of water in their wine. Now, our favorite approach to solving problems in Canadian healthcare is to throw more bodies at the problem. We're really good at that. Today, we have more doctors than ever, per capita in sheer numbers, more nurses, you name it, more of everything. If something isn't working, we do more of it. Sounds logical when you say it out loud, right? But that's what we do. Now, Einstein had a good comment about that kind of philosophy. He said, insanity is doing the same thing over and over again and expecting different results. We do the same thing over and over again, but with more money. And we've done so for 50 or 60 years. Impediment number 5, public versus private. A hush fell over the room. He said the dirty word, private. In Canada, nothing can bring a discussion of reform to a halt more quickly than invoking the specter of privatization. Evil capitalism. Imagine. My God, we're afraid of private enterprise in Canada, aren't we? Virtually everything in our lives is purchased privately. Food, housing, clothing, cars, sometimes even education, even love. Tinder's a business, right? But perish the thought that we purchase health services. We seem to put that in a special, magical category. Yet there's a lot of hypocrisy on this issue because there's a lot of private healthcare in Canada. 30% of healthcare services are purchased privately in this country. That's one of the highest rates in the developed world. Most countries, it's about 85% public. Canada, only 70% of our spending is public. But we make this weird exception for physician and hospital services. For some reason, they're considered sacred. They must be 100% publicly funded. Why? Because that's how it was done in the 1950s. Every country with a decent healthcare has an element of private care. The real question to me is not whether we should have private care, but how it should be regulated to ensure that people are not denied access or not denied affordable care. That's what matters, not who the provider is, what kind of structure they work in. It's about getting the public-private mix right, and we don't have it right in Canada. There's no question about that. I like to use the metaphor of the Medicare basket of services. And right now we have a basket that's very narrow and very deep. It has physician and hospital services in it. And all the other things are outside. You know, what sense does it make that we fund 6% of dental care publicly, 45% of drug costs, but 100% of hospital care? We need to take that basket and make it wider and a little less deep. So if we're going to have private care, let's have a little bit across the board, but ensure that everyone has access to every service who can afford it, or who can't afford it especially. Now, resources are abundant. We're a wealthy country, but resources are still finite. We have to spend on other things but healthcare. Currently, 42% of provincial budgets go to health. I don't know if that's enough or if it's appropriate. Certainly health is important, but we know it can't be 100%. So we have to ration. There's another dirty word, rationing. But again, every country has to ration. Most are quite much more open about it. Do you ration by limiting access to some services, or do you ration by making care unaffordable? Now, the US, as we know, takes the latter approach. They deny care to people who can't afford it. Currently, 28 million people are uninsured in the US. If the Republicans manage to dismantle Obamacare, it'll be 60 million. That's how they ration. They ration for the rich. Other countries, including Canada, tend to limit access to care. That's why we have waits. That's why we say no to some things. And they provide a private outlet for some, so the wealthy can purchase, but everyone still gets the basic care. And again, every country does this, but Canada doesn't do it quite as well as others. We don't have the balance right. We have far too many limits on access. By this, I mean we have too many waits, and we have far too few alternative outlets, far too little choice. Again, these are structural issues. They're fairness issues. Successful reform must both improve access and contain costs and maintain quality. Not an easy thing to do. Really difficult mix. But again, many countries have done it relatively well. No country is perfect. Everyone has flaws, but they tend to have the mix a little better. And the countries that do it successfully often spend the same or less than Canada. We really don't get value for money. In the Commonwealth and OECD studies, Canada's often near the bottom. The US is the bottom, but they're an outlier. I don't talk about them. But we tend to be, of 11 countries always in the Commonwealth studies, we're always number 9 or 10. When it comes for value for money, we're right there at the bottom as well. Any way you measure, Canada can do better. We have to fix things. But we've dug ourselves in this really deep hole by waiting to act. So it's come to feel like an impossible task. But I hope you take from what I say tonight, even though it's quite negative, that it's not impossible. It can be done. We can take inspiration from many places. Now, the number 6 impediment is fear. The Canadian public, for me, is one of the biggest barriers to reform. And it hurts me to say this, but I think it's true. We're far too accepting of mediocrity. We're not near demanding enough. We sit in our emergency rooms for 8 hours and we curse under our breath. But that's all we do. We don't get too worked up. We tolerate all kinds of inadequacies in the delivery of care. Chief among them, these waits. Somebody told me today about a 24-month wait for an orthopedic consult. An elderly woman who's in pain, can't walk. She has to wait 2 years to see if she can get surgery. Who knows how long the wait for surgery will be? That's an obscenity. It shouldn't exist in a country as wealthy as Canada, and in a country that spends as much as any country in the world, save one. So, why are we so tolerant and accepting of mediocrity in Canada? Why do we individually and collectively engage in this kind of ritualistic self-abuse? Why are we known worldwide as the country where we wait and wait and wait? I think we do so principally because of the mistaken belief that care is free. Again, that word in quotes. It's free, so I guess it's okay if I wait. It's free, so I guess I can wait to see the specialist. It's not okay. It doesn't exist anywhere else in the world. As I said earlier, many countries deliver far more extensive care, and they do so without embarrassing waits, and they do so at lesser cost. I know I'm being repetitive, but I'm trying to drive home the message. And I'll give you an anecdote. I was in Spain not too long ago. I was in Barcelona, and I was on holidays, but I went into an emergency room to see. I was walking by a hospital, said, I'll go in and see what it's like. And so I asked the triage nurse what the wait time was. And she spoke very good English. I told her where I was and what I was doing, and she spoke very good English. And I said, what's the wait time? And there was a long silence, and a puzzling look came over her face. And she said, it's an emergency room. Why would people wait? And I was bowled over by the logic of her statement. But then her question to me was this: where are you from? And I said, Canada. Oh, Canada. That's where we got our national anthem from, I think. Oh, Canada, yes. Let me give you another example. In Canada, 1 in 3 patients wait for more than 3 hours in the emergency room. This is the latest Commonwealth study. It's not unusual for those waits to stretch to 24 or 48 hours. I saw a story today about a Brampton hospital, 70-hour wait to be seen in emergency, an elderly patient on a stretcher in the hallway for 4 days. In France, fewer than 1 in 100 patients have a 4-hour wait. It doesn't happen often because they get angry. If the waits for care that we consider normal in Canada occurred in France, there would literally be another French Revolution. I can guarantee it, and I can say that, I'm French. It would not be tolerated in any way, shape, or form in most developed countries in the world. But in Canada, heads never roll. There's very little accountability. Who's responsible for that wait time? 70 hours. Who's going to be fired tomorrow? Nobody. It's going to be a story on the CBC tonight. We're going to shake our heads, and that'll be that. In Canada, we're way too polite. We're fearful of making demands. And why is that? Well, I think because we often think the alternative is going to be something worse. And I hope I've convinced you tonight that it's not. It doesn't have to be worse. It can be much better. Now, my list of impediments is far from exhaustive. I'm sure you can all think up a few more. But I think I've been sufficiently depressing. So let's talk about change. Anyone who's taken Psychology 101, and all of you in university probably have, it's the class with way too many people in it. You can sleep through it because the prof doesn't know your name. That's Psychology 101. But anyone who's taken that course and listened even a little bit will know that change is really hard. I'm not suggesting any of the things I'm proposing or others are proposing are easy. One of the biggest problems is we tend to view change as cataclysmic. It's going to be a massive upheaval. It's going to be horrible. But that's not true. If change is done properly, it's rarely a discrete or a single event. It's rarely a cataclysm. And it usually doesn't happen in a linear fashion. You change a lot one day, a little bit the next, sometimes 2 steps forward, 1 back. That's how change occurs in the real world. Whether it's an individual or a system, behavioral change tends to occur gradually, over time. So that's what we have to do in healthcare. We don't have to wait until it gets so bad that there's a crisis and we have to act. What we should aspire to is continuous improvement. And as I said, we have some of that, but we don't have enough of it, and we don't value it. Psychology 101 also tells us the most important element to successful change is having support systems, having incentives and encouragements so you don't fall back on your old habits. Do we have incentives in Canadian healthcare system? Not really. We have many disincentives. Lie low, do what you're doing, don't make a fuss. That's what gets rewarded, politically and otherwise. So practically, how do we get over this fear of implementing change? How do we support and encourage those who want to improve the system? And there are many. I don't know any frontline worker who doesn't want things to be better, but they're frustrated, and often they give up, and that's really tragic. Now, there's a lot of research published on this topic, and I'll try and summarize it in a non-academic fashion. How do you support change? Well, you engage frontline workers, first and foremost. Change will never happen unless nurses and doctors and PSWs are on board. They are the heart of the system. It's a labor-intensive system, and there has to be buy-in. Without that, it's a non-starter. No matter what patients want, it won't happen. You have to promote evidence-informed policymaking. We have a lot of data on how things can be better. We have a lot of research, really good health policy research, much of it out of this school. We have to talk about it. We have to implement it. We have to incite people to do so. We have to engage patients and clients and citizens more broadly. Most of all, we have to have them believe that by making changes, we're going to improve their care. And that can be a tough sell. A lot of skepticism out there. We have to do practical stuff. We have to build organizational capacity. We have to give staff and patients the tools and the power to make change. In some instances, that's going to require huge influxes of money, but hopefully savings over time. But there has to be some leaps of faith in there. We have to create supportive policies and incentives. You have to reward those who make improvements. You have to give people encouragement every day. And you have to focus not just on individual needs, but on population needs. I've often heard doctors say the only person who matters is the patient in front of me. And I don't think that's true anymore. I think that in every patient encounter, there are 3 people in the room. There are the patient, there are the healthcare provider, and there's the system being the representative of the public. And we have to be responsible as much to the public as to the individual. Again, that's an uncomfortable change, but we have to talk about that. Now, ultimately, change won't occur unless there's pressure, relentless pressure to break through the inertia, because inertia is comfortable. As bad as things are, at the end of the day, we tend to get pretty good care. We forget about the wait. It's kind of like childbirth. My wife gave me this analogy. It's hell to go through it, but you got this nice little baby at the end. So you kind of forget. You forget the pain. You only remember the good stuff. And it's a bit like that in healthcare generally, unfortunately. So what's the formula for reform? Is there a magic formula for sparking change? Well, recently I was at a conference. I spend my life at conferences. And I actually heard someone articulate a mathematical formula for change. And I want to share it with you. And I really wish I had paid more attention and I could give you the person's name and affiliation and proper credit, but I'm sorry I don't have that information, but I'm still going to steal their thunder. Now, in my business, we call that research. We don't call it stealing, but there you go. So here's the formula. And at this point, it might be useful to have a PowerPoint, but I know you guys are smart, you can retain this. So here's the formula. C equals D times V times F greater than R. So let me define each of those letters so the formula makes some sense. C. C is for change. Change equals dissatisfaction times vision times first steps, the sum of which is greater than resistance. When you ponder that, it's actually a brilliant formula. C equals D times V times F greater than R. Change equals dissatisfaction times vision times first steps, the sum of which is greater than resistance. The formula touches on really important elements that are required for reform to occur. You need some dissatisfaction. You need a burning platform to mobilize or scare policymakers or politicians into action. I think we have many burning platforms in Canada. The most obvious one today is hallway medicine, people on stretchers for days on end. That should mobilize us. That's not a simple issue of needing more hospital beds, it's an issue of fixing a whole system so that people can flow through properly. You need V, vision, a clear proposal on how things should be done differently. And as I said before, we don't have much of a vision in Canada. We don't have a system, so we have to start with that. Then you need some action. That's F, first steps. We need some first steps to show we're on the right road, to show that change can happen, and it can be inspiring, and it can work. And we have many first steps available to us. Canada's a land of pilot projects. We do fabulous pilot projects, but we don't take the next steps. We don't scale up. And finally, you have to make this change feel unthreatening enough to overcome the inertia that pervades, as I said. And I think all those elements exist in healthcare, except maybe the last one. Again, in Canada, we have this almost pathological fear of change, a fear of failure. We'd rather do things in a mediocre way than risk doing them worse briefly before they get better. We have to get over that mindset. I think we'll never improve the system unless we take risks, unless we're willing to have some failures. And we don't value failure enough in our health system. It's not a bad thing. There wouldn't be a Microsoft without many failures by Bill Gates. There wouldn't be an Apple without many failures by Steve Jobs. Michael Jordan, when he talks about his career, always starts by talking about, I missed 23,000 shots. I missed 24 game-winning shots. He talks about the failures because he says that's what ultimately made him great, the need and the will to do better. We have to be willing to build on our successes in Canada as well. I often feel that we've solved every single problem in Canadian healthcare at least 10 times. But we can't be sufficient to do it in a pilot project. You have to take the successes and spread them and invest in them. Now, there's one word that I've deliberately avoided in my long talk tonight, and that's the S word, sustainability. I hate that word. If I had a nickel for every person who told me our health system was unsustainable, I'd be a very rich man. I'd be on the beach in Guadeloupe. I wouldn't be here tonight. But I don't believe for a moment that that's true. Our health system is as sustainable as we wish it to be. That's the attitude we have to have. We have to recognize, too, that sustainability is not a synonym for the status quo plus more money. A sustainable system is one where patients get the right care at the right place at the right time for the right price. That's what we have to aspire to. Right now, our health system is best described as islands of excellence in a sea of mediocrity. Or the quote I gave you at the outset, where it's good, it's very good. Where it's not good, it's awful. There's a little bit too much awful. But there's a lot of good that we can scale up, and we can accelerate the scaling up. We need to decide what we want to sustain and then make a plan. Or better yet, we need a vision. I think all the impediments to reform are fixable because all of them are self-imposed. There's no reason for any of them. The first step of health reform is the most difficult one. It's to stop talking about it and start doing it. So I want to thank you for your attention tonight, and I'd welcome any questions or comments from you. And don't dilly-dally tonight, get back and start fixing the health system. Thank you.